Part 2 of diabetes care. As we previously stated in the first presentation, patients with diabetes will need to be checked for comorbid conditions. This includes screening for renal, vision, neurological function, cardiovascular disease risk, and others. A team approach has been proven to improve patient outcomes. However, the patient must also assume quite a bit of responsibility in his or her care, with the ultimate goal of maintaining tight glycemic control. We mentioned that intermittent self-monitoring of blood glucose should be conducted for prediabetes and for type 2, and that continuous glucose monitoring would be more helpful for the patient with type 1 diabetes. Monitoring helps to understand if the treatment is appropriate or if adjustments need to be made. For example, if A1C goals are not met in type 2, we generally begin to add insulin. All patients with diabetes, regardless of the type, will need medical nutrition therapy, but many will also require medications to attenuate blood glucose levels. The goal is to match insulin to carbohydrate consumption and keep the blood sugar stable and within a target range. Oral agents may also fend off the need for insulin or act as an adjuvant to insulin therapy. Metformin, along with nutrition therapy and lifestyle changes, may slow progression to full-blown diabetes. Usually, insulin will be needed when oral agents are unable to keep A1C less than 6.5 to 7%. This is a summary table of oral agents used for diabetes treatment as of 2013. You'd want to pay special attention to this table. It reflects the information presented in your book, and there will also be a matching question on your test so that you can match the drug type to its mechanism of action. SGLT2 inhibitors are being tested as a new oral agent for glycemic control. The mechanism of action is prevention of glucose reabsorption in the renal tubules. Phase 3 trials are ongoing as of 2013. The next chart summarizes the action times of different insulins. The short-acting insulin like Lispro, Aspart have an onset of action of approximately 15 minutes. They peak 1 to 2 hours after injection and have a duration of action 4 to 6 hours. This is important to remember when you get to the lessons on the insulin pump. Regular human insulin can have an action ranging from 30 to 60 minutes with peak concentrations between 2 and 4 hours and a duration of 6 to 8. The longer acting insulins are less predictable than the short-acting ones. Insulin pumps only use short-acting insulin. This means if a patient is disconnected for more than an hour, they can see a rapid increase in their blood glucose levels and a rapid drop of insulin. Long and intermediate acting insulins must be given by syringe. Remember that medications should be individualized to achieve optimal glucose control. You need to know these numbers as well. Postprandial blood sugar will not rise more than 40 milligrams per deciliter if the diet and the dose is correct. Preprandial blood sugar should be somewhere between 70 and 130. If a preprandial blood sugar is elevated, the patient will need a correction bolus to cover what they're about to eat and the elevated blood glucose. The insulin pumps today are designed to calculate a correction dose, but you'll also learn how to do it. Postprandial blood sugar should not exceed 180. If the pump is delivering a sufficient amount of glucose to cover the carbohydrates that were consumed, a 1 hour postprandial blood sugar should be 140, and at 2 hours you should be back in the acceptable range. For patients trying to achieve glucose control, algorithms can be used as a guide to normalize blood sugar. For the patient who's on an insulin pump, the pump can be calibrated to cover rises in blood sugars even during the day. Perhaps a person has an increase in blood sugar, let's say, at dinner time, and so the pumps can be calibrated to deliver more insulin at certain times than others. Regarding the complications that are associated with diabetes, cardiovascular disease is very high among diabetic patients. Screening, again, is very important for hypertension and for indicators of cardiovascular disease markers. The goal is to keep the systolic blood pressure less than 130 and a diastolic less than 80. The DASH diet, dietary approaches to stop hypertension, weight loss, exercise, and medications are called for in these cases. An ACE inhibitor or an angiotensin receptor blocker would be very beneficial in these patients, not only to address cardiovascular disease, but to spare kidney function in diabetes. Many times doctors will put their diabetic patients on an ACE inhibitor anyway, just to protect the kidneys. Smoking cessation is also of benefit. Diabetic patients may also have dyslipidemias. It's important to check their lipid profile at least once a year and make sure that the patient adheres to the dietary recommendations. Often, because fat does not affect blood sugar immediately and overtly, patients feel like it's okay to cheat here, and they'll eat fried foods and foods that contain a lot of fat. However, dyslipidemia is a problem that is particular to diabetes. They may need statin drugs, extra patient education. The goal is to keep LDL-C less than 100. And of course, our overall goal is an A1C less than 7, preferably 6.5, but this can be adjusted based on age and race. We know that older patients don't do as well with an A1C that is low. We tend to let them be a little higher at 7.0. Patients should be screened for kidney function every year. This is particularly true with a newly diagnosed type 2, since they may have gone undiagnosed for a long time. And type 1 should be checked at 5 years after diagnosis. Older patients will need more frequent and extensive monitoring. We're looking for micro and macroalbuminuria. You need to know the numbers here. Signs of albumin in the urine are an indicator of decreased kidney function. You can also collect serum creatinine to estimate the glomerular filtration rate and stage the level of kidney disease. We know that a patient who has a GFR of less than 60 is at greater risk of kidney failure, and there are different standards of treatment based on the level of kidney function. To protect the patient who has diabetes from kidney failure and loss of kidney function, we want to keep the protein level to about 0.8 grams per kilo. The typical American diet tends to be very high in protein. Also, a lot of people are interested in low carbohydrate diets. Well, this is going to result in increase in consumption of protein. Again, not healthy for a patient with diabetes. We encourage people to have a diet that's 50 to 60% carb. There are going to be a few diabetic patients, though, who can't tolerate that much carbohydrate, and we might put them on a 40 to 50%. That is naturally going to increase their protein intake. And so they must, you have to weigh this blood glucose control against the effects of extra protein on the kidneys. Patients need to be checked for neuropathy, and you see the screening recommendations here on the slide. Podiatry consults are necessary for scrupulous foot care. Of course, you want to check the ankle brachial index for peripheral artery disease. It's important to conduct simple neurological screening tests, such as the monofilament testing, as you see displayed here on the screen, where we're looking for sensitivity. We had a patient one time who came in and told the physician that she didn't feel good and her foot just didn't feel right. And so he removed her shoes and looked at the bottom of her foot and found a fishing hook, a treble hook actually, embedded in her foot. He took a pair of pliers and removed them, and she never flinched. She simply didn't feel the pain because of the extensive neuropathy from untreated type 2 diabetes. Of course, retinopathy is also a problem. Again, very important to prevent. Eye damage and comprehensive eye exams are in order. Additional comorbid conditions to think about: obstructive sleep apnea, hearing loss, fatty liver disease, hormone imbalances. Dentists are often trained to ask patients about signs and symptoms of diabetes because they tend to have more periodontal disease and cavities. Cancers may be higher in certain types of diabetic cases, increased risk of fracture and cognitive impairment. A complication of type 2 diabetes is hyperglycemic hyperosmolar non-ketotic syndrome. A lack of insulin deficiency reduces the breakdown of fat, so ketones aren't present. So that's why it's typical in type 2 patients. It's exacerbated in stress, dehydration, or a major health event such as a heart attack. Other complications we can look at in terms of acute problems. Hypoglycemia is typically caused by too much insulin and too little food. Can also be brought on by excessive exercise and alcohol and medications. Alcohol, when consumed in a diabetic patient, will stop the liver's slow release of glucose. And so it results initially in hypoglycemia, but once the liver has finished processing the alcohol, the patient could have a rebound hyperglycemic event. Acute hyperglycemia in diabetes can be brought on by illness. This is why, even though a patient with diabetes who has nausea, vomiting, and diarrhea is also encouraged to continue to take their insulin and check their blood sugars more frequently. Another reason for hyperglycemic events could be that the insulin is weak. Maybe their insulin pump batteries are weak. Stress. And if left unchecked, it can develop all the way to ketoacidosis. This results in metabolic acidosis and death if, again, left unchecked.